How's it going, guys? We have a medium difficulty question for Neuro, Step 1 Internal, and Medicine 2 CK. So we've got this 40-year-old who seems to have a variety, multifarious neurologic issues. And you're like, what the hell? No idea what's going on here, okay? I'm going to make this very clean and easy. Answer is ALS, choice A. Now, this is what you need to know. There's two things that are going to show up in an ALS vignette, okay? Number one, no sensory abnormalities, which here they say no sensory abnormalities. Number two, the combination of upper and lower motor neuron findings. Okay, so you get a big 15-line bullshit paragraph. They say something about a sensory abnormality in there. You'll say, cool, not ALS. Okay, so we have no sensory abnormalities. Upper motor neuron findings tend to be up findings, brisk reflexes, hypertonia, Babinski sign. Lower motor neuron findings tend to be weakness, atrophy, fasciculations. So we've got both here, okay? With the no sensory abnormalities, that's easy, that's ALS. Pathophys is thought to maybe be due to glutamate toxicity. You can give riluzole, an NMDA glutamate receptor antagonist. That's more lower yield. I just want you to know, as I already just harped on, number one, no sensory abnormalities. Number two, the combo of UMN and LMN findings. That's ALS. Very easy, very clean. Okay, let's just hop to the others. Guillain-Barre, wrong fucking answer. It's going to be T-cell attack against Schwann cells. So segmental demyelination, peripheral nerves, ascending paralysis, decreased reflexes, abdominal cytologic dissociation, which is high protein, low cells within the CSF. You're going to do electromyography, nerve conduction studies, next best step in diagnosis, and you can treat with IVIG and plasmapheresis. Steroids, wrong answer. So only about 1 in 5 questions, I would say, for Guillain-Barre will they give you the very buzzy nonsense Campylobacter jejuni guy went to a barbecue and his bloody stool. They're not going to do that. They'll just say random 24-year-old dude who's got 1 month history of ascending paralysis. That's it. And it's just Guillain-Barre. It's not complicated, okay? Wrong fucking answer. Choice C, MS, wrong fucking answer. T-cell attack against oligodendrocytes, which I should juxtapose this with Guillain-Barre. If you had to choose, you're going to choose Schwann cell, peripheral nerves, but multiple sclerosis, you're going to choose oligodendrocyte, the CNS. And so a T-cell attack, not just against oligodendrocytes, but also they can have myelin basic protein. That I've seen that in NBME answer. T-cell attack against myelin basic protein. Woman, 20s to 40s, they don't have to say she lives far from the equator. And of course, relapsing, remitting, they say there's episodes over time, that's buzzy. But the two things, as per my observation across NBME exams, they want for MS, number one, the eye findings. So optic neuritis and INO, MLF syndrome, okay, internuclear thalanoplasia, medial longitudinal fascicular syndrome. I talk about this stuff in my ophthalmology PDF. Go to my ophthalmology PDF, okay, and my neuro PDF. I talk all about this stuff. So number one, the eye findings in MS. And number two is going to be urge incontinence. Some students say, oh, I've read you can get overflow incontinence. I haven't seen that on NBME exam. I'm not talking about Qbank bullshit. I'm talking about NBME exams. They give urge incontinence, okay, hyperactive detrusor muscle. So they want IV methylprednisolone as the treatment for acute flares. And they want interferon beta between flares to decrease recurrence. There's a whole slew of drugs that can be used, but I've seen interferon beta assessed, and they want baclofen for spasticity, the GABA B receptor agonist. Multiple sclerosis, wrong fucking answer. Choice D, PMR, wrong fucking answer. So when we want to differentiate polymyalgia rheumatica from polymyositis, there's 2 points you need to know, okay? Once again, making this very clean and easy. So both conditions can present with proximal muscle pain and stiffness. If you had to choose one, you'd say, oh, I thought that's PMR, polymyalgia rheumatica. Yeah, I mean, very buzzy, you'll hear that. But they can give you polymyositis where patient reports subjective pain and stiffness proximally. So it's not how you differentiate them. So both can have pain and stiffness proximally, both can have high ESR, both can have high CRP, both can have low-grade fever. The way you differentiate is that only polymyositis will have increased CK and or weakness on physical exam, okay? And or, can be either or. Okay, that's what you're going to see in polymyositis. So a patient can walk through the door and say, oh, I've got, pain and stiffness in my shoulders and weakness. And then you do the neurologic exam and there's 5 out of 5 strength in all extremities. That's not weakness, okay? You got to be careful. It's on physical exam, the weakness and or increase in CK. It's polymyositis. So PMR can be associated with giant cell arteritis, temporal arteritis as well. And this is not inflammation of muscles themselves. It's inflammation of synovia, joints, tendons, surrounding muscles. Polymyositis, in contrast, this is inflammation, CD8 plus infiltration of endomysium, okay, surrounding muscle fibers. And if you get skin findings with polymyositis, then of course that's called dermatomyositis, okay, the Gaucher papules, Shaw sign, mechanics hands. Anti-Jo1, MI2 antibodies for polymyositis increase risk of malignancy as well. And just before I close out, because some students are about to trip out right now, you might ask why there's increased creatinine kinase in this vignette for ALS, because I didn't address that before. I've seen this in NBME questions. This can theoretically be due to increased muscle tone and or atrophy that's seen. Okay, it's nothing to freak out about, but I'm just letting you know. I've seen increased CK in ALS vignettes, but it's not super important. Polymyositis, wrong fucking answer. You know the deal on team, make more content, like my style scrimmage. Appreciate your time. That's it.